This is the Psychcast by MDedge. And welcome to episode 152 of the Psychcast by MDedge. Remember, you can email the show at podcasts@mdedge.com. You can also follow us on Twitter at MDedgePsych. And we love the 5-star ratings if you deem us worthy, and any sort of review that you leave on iTunes or Apple Podcasts. If you have a desktop or Android device, you can find a way to iTunes or Apple Podcasts. We take those reviews seriously, and they have helped impact how we've improved the show in the past. So we really appreciate that if you find it necessary. Thank you so much. So let's talk about episode 152. In this episode, Dr. Oliver Freudenreich joins the editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris, to talk about principles of pandemic management among patients with serious mental illness. As we round the corner on 2020, the pandemic is really setting in. Different portions of the globe, including the United States, are on fire, and the mental health echo pandemic, as it has been coined and discussed in past episodes of this show, the mental pandemic, the echo pandemic, is really starting to take effect. So Dr. Freudenreich, you want to learn more about him, you can click links in the show notes, which were authored by Dr. Jacqueline Posada. And with that, let's welcome the editor-in-chief of MDedge Psychiatry and the host of this show, Dr. Lorenzo Norris.
This is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. Today we are pleased to have Dr. Oliver Freudenreich with us from Harvard, and he serves as a director of the MGH schizophrenia program there. So Dr. Freudenreich, welcome to today's Psychcast.
Thank you for having me.
So Dr. Freudenreich, as we're recording this, we are seeing, we are really in the second surge. We have over 250,000 Americans who have lost their life. We have it, I think by my last count, or what I just saw, 11 million total cases of COVID. We all know that actually that those numbers are actually, if you will, estimates, and they most certainly can actually be higher in terms of like the true, if you will, number of deaths and caseloads of COVID in the country. Now, given that we are in the second surge, full on, many of our colleagues are experiencing, if you will, hospitals or ICU beds at full capacity. Many places have implemented their surge precautions. I was wondering if you could speak to us about a recent article that you and your colleagues wrote in regards to COVID-19 and management principles, particularly as it pertains to those with serious mental illness. And I wanted you to kind of prime us to really start to think about, if you will, those principles of pandemic management that you folks at MGH, like at maybe even going from the start of the pandemic, how you developed them, how they came about. But please share with us in the audience, if you will, these principles of pandemic management.
Yeah, no, great. Thank you for inviting me to talk about this now.
Yes.
Because I think this is exactly the right time point to kind of really revisit what we have learned. So the article that you mentioned, I had the privilege of working with two colleagues at MGH and Tufts here, Dr. Contos and Dr. Corquist, to really put together a document at the beginning of the pandemic where we started to think about, well, what is it that clinicians actually ought to perhaps know about COVID-19 vis-a-vis patients with serious mental illness. And maybe it is worthwhile, going back in my case here, I said I'm up here in Boston on the East Coast in Massachusetts. And it really, for us, became very serious in March. So I said I'm at MGH, but I also work in a community mental health center, the Eric Lindemann Mental Health Center, a typical community setting, in Boston, but still with I think a patient population, people with serious mental illness, with schizophrenia, serious bipolar disorder, substance use, that many clinicians will recognize. Managed by, shout out here to North Suffolk Mental Health Organization, who runs this clinic, and I work as an academician on their behalf, if you will. So we realized in March, this is not good. This is just something that we didn't expect. I am from Europe, you might have recognized by my accent. I had some, if you will, some early information about colleagues in Germany, Italy, and I thought, we got to start to think about this. So in March, we started to think about, well, what's going to happen here to our little clinic and patients in our clinic, specifically perhaps with regards to essential services. We anticipated a worst case scenario that we had to shut down or significantly reduce the services that we can provide. And there were two things that we identified, just to give you a concrete example. We can come back to this later, perhaps. Clozapine, we have a very large clozapine clinic because clozapine, as you know, and as the audience may know, requires regular blood work monitoring. And long-acting injectables, which of course has to be done in person. So these are just two areas that we identify as from a service perspective, where we needed to figure out how to continue these services. And as we were thinking about this, we realized, well, we have to go back and find some books about pandemics. For most of us, my generation, and it's interesting because I will say something that is not quite true. We have never experienced pandemics. And then as you start to read about it, you realize, of course we have. HIV, MERS,
yes,
SARS, Zika. There are actually many, many instances. And then when you look and you hear people say, oh, nobody could have known this. Well, not true. ID has warned us forever. There's going to be a big one coming. So it is interesting from my perspective, because at this stage in my career, I had to hit the books a little bit and talk with colleagues about just general pandemic management, because the rules change. I mean, that is the one thing I think we've all recognized. A pandemic is a big deal. It's a really big deal for medicine, for society, of course, but also for us in medicine. And it's slightly different compared to other disasters because it's an ongoing event. And as opposed to other disasters, it affects us, the workforce. We're directly in the midst of this. We're in the same boat for once with our patients, as opposed to waving from the safe shore, telling them what to do. So that's a very curious few months, I think, where we had to get our head around this idea that this is going to be a big deal. We're going to be directly affected. We're going to think about, the workforce protection as one of the major challenges for our clinic and for our hospital. Other challenges that, you don't really think about until you have to think about it is a pandemic has whatever the medical footprint is, it has a much larger psychological footprint.
Absolutely.
So this idea that on the medicine side, it depends on the nature, of course, of the infectious disease. That part is going to be what it's be, but 100% of the society is going to be affected psychologically, even if only a minority of people will actually contract COVID or die from COVID. So this mismatch a little bit between the biological footprint and the psychological footprint, and how to manage, this psychological footprint. The anxieties about it, the information is something that I really had to read up on.
Let's dive right into that, Dr. Freudenreich, in regards to the principles of pandemic management and all of us having to educate ourselves in regards to the pandemic or previous pandemics. And you articulated so wonderfully that we're actually all, one big difference amongst many is that we are all in the same boat and we are all affected by the stresses of the pandemic. But let me start with your role in a community-based clinic and a hospital. And I'm going to jump to community-based clinic because I'm very curious. All right. When I think about in terms of principles of pandemic management, can you walk us through just maybe let's start with masking. What type of things did you all think about in terms of making your outpatient environment safe in regards to masking and the use of PPE?
Yeah. So, I mean, I just want people to think back, depending what part of the country you live in, different timelines for different states. In our state in March, when it hit, we knew very little. Guidelines shifted.
Yes.
It was chaos. I mean, I hate to be so blunt here, but it was a chaotic environment with different organizations issuing different guidance, and we had to somehow figure out how to stay afloat. So I am proud that as a clinic, for example, North Suffolk, with help from MGH, that very early, for example, we said everybody's going to wear masks.
Okay.
Clinicians and patients when they come in. Before, the CDC became very clear about the role of masks because it made sense. I was very early, and not to present me here as the all-knowing person, but I thought this is really bad if this is airborne. And why not? Why not do something that perhaps may have an impact? PPE was a big deal in the beginning. We didn't have it. So at least we did have the masks. That never really was an issue. The other thing we implemented very early was trying to limit the number of people in the clinic.
Okay.
And really, because I have trainees that forced me to really think about other people that respond to me. Very early we implemented kind of I call it in and out. People need to be seen, for example, for blood work, but in and out. This we decided was not the time in clinic for a 45-minute psychotherapy session. Now, Lorenzo, if you don't mind me adding at the same time. What I'm not saying is in and out and then forget about the patient until you see them next. And that is something that took quite a while to really figure out, but have a much more flexible treatment delivery model, meaning people do the things in person that are absolutely critical to be done in person, but otherwise it's telepsychiatry.
Okay. I want to follow up on that. Going back to at the height of the pandemic, or not the height because we're getting a new height, but we go back to March, as you said before.
Yep.
PPE was in short supply. We were just learning this. Again, I hear in terms of principles of management here, absolutely early on, masking. I'm assuming surgical mask. A lot of things have come out now in terms of, because I remember back then we were going back and forth about how do you absolutely need an N95 versus surgical mask?
No, I'm talking about surgical, yes. Yeah.
Surgical mask. And right now to folks listening, I can say at my site at GW, everyone's surgical mask, as well as in the hospital, full on eye shield and face shield covering. So, but what you said, Dr. Freudenreich, in regards to that in and out, I think that's a very important principle of pandemic management. What needs to be done, you have to determine in your group or in your setting, if I'm hearing you correctly, what you absolutely have to do in person, and then what can actually be done via telehealth. And if you haven't done that already, I would assume most people have, but it's a very useful thing to do. And you also brought up another point, which is huge. Trainees and who actually needs to be on site and who needs to be doing what. I think that all gets into exposure control, all right, for our patients and for ourselves, and also really, again, going back to that idea of essential services. So we've talked about just kind of, if you will, environmental safety and, if you will, kind of biosecurity safety. When you implemented the in and out and the mask, how did you attend to the well-being of your patients? Because you're working with a population with serious mental illness, similar to myself when I work at GW Hospital, and our patients come in various states of distress, paranoia, delusions, outright, if you will, emotional dysregulation. And that can be a bit of a challenging situation. I'm wondering, were there what other protocols or principles of pandemic management did you all utilize in helping your patients adjust to the normal that is the pandemic now?
Yeah, let me maybe answer this in an indirect way.
Sure.
We looked at really what are going to be important treatment principles for us, treatment priorities going forward. Infection control, we already talked about.
Yes.
Clearly. Whether we like it or not, in psychiatry, we're going to be with masks, being part of the solution to control this pandemic. Which, by the way, is an important role that all physicians, I believe, all healthcare providers really, also when the vaccine comes, we're going to be increasingly engaged in being part of the solution, despite our training as psychiatrists and not ID docs. Relapse. So it's in our clinic, which is really serious mental illness and focus on psychotic disorders like schizophrenia, serious bipolar disorder. Relapse prevention, absolutely critical. So we have a lot of, I'm not in an acute setting like you. We have a lot of stable patients, but they're stable because they're in treatment, engaged in treatment, on the right medicines. Clozapine, for example, we have a very large clozapine clinic of over 200 people. Long-acting injectables. Okay. Absolutely critical that there's no gap in treatment, just from the psychopharmacology side, because the last thing you want is a patient decompensating because they didn't get the injection, they didn't get clozapine. As you can imagine, on the acute side, the last thing you want is to have a manic patient who potentially, gets infected in the community because of lack of judgment due to their illness, and then overwhelming an already strapped, acute care system. So that was a very clear point for us. And somewhat related to this was this idea that people need to remain engaged in treatment. So not just the psychopharmacology piece, but treatment in general. And I think that gets me back to what you asked. So what about loneliness, anxiety about the pandemic? Maybe, which is a big risk, at least at the population level, managing the distress with alcohol. In pandemics, reliably, alcohol use goes up. Every society can show this in epidemiological studies. And other health behaviors may go down. And here, I have to say, that has been eye-opening. Because I think your question implied a little bit, well, how can the patients that we treat in the community mental health center, how can they manage? Isn't there going to be a lot of distress and they struggle to begin with? They have surprised us. Many of my patients, I think, have surprised all of us with their resilience. And the idea of outreach, and telehealth is a big word. Let me just say, our outreach has not been mostly video conferencing, Zoom-based or some other platform, but phone calls.
There is telehealth.
But I cannot tell you how rewarding also on my side this has been. People thanking you for checking in with them. Even brief phone calls from a physician go a very long way. If you don't mind, Lorenzo, I would like to actually stick with this issue of phone calls for 1 second.
Please go for it.
Because what has happened during this pandemic, and that is how shall I say? It is somewhat discouraging that it took a pandemic to get to that point. The recognition that we have a lot of rules and regulations that really get in the way of good patient care. Okay, why do we not routinely reach out in a proactive way? Using phone calls and tell other Zoom-based telehealth because it doesn't get reimbursed, or there's hurdles left and right to do this. So we have really focused on this office-based treatment model, just because that's the model that fee-for-service that gets reimbursed the easiest. Reimbursed the easiest. And there were always rationalizations to my mind. Oh, patients are not going to be able to do it. They're not going to like it. All not true. Great acceptance by not all patients. Don't get me wrong here. There is a digital divide that we have to think about if we think about the future. But for the vast majority of patients, they feel that was really a lifeline that they needed during this initial first surge. And we have been able to kind of continue to do this, hopefully to get us to this next one.
All right, Dr. Freudenreich, I want to thank you for bringing that up in regards to, talking about the resilience of our patients with serious mental illness, and we should never underestimate that. In regards to the telehealth, particularly the phone calls and the reaching out, a bit of a compound question here, or a couple of questions here. First question is, are you all, particularly in regards to clozapine, we know the dangers, if you will, of like missing that as well, or the long-acting injectables. Is your clinic, are you reaching out more proactively or about the same? And also, are you finding yourself doing more follow-up or more brief reaching out with the phone? I don't know if this is a change or if it's still standard practice.
Yeah. Clozapine has always been a somewhat separate issue in psychiatry. We have a clozapine clinic, so in part because of the mandated blood work, part of the protocol is if somebody doesn't show up, there is automatic outreach. I wish we had this treatment model for all of our patients. So I think what we have learned, and let's just stick with clozapine as an example. I was part of an international working group at the beginning of the pandemic, and we did publish its reference in the paper something. I'm the senior author. Dan Siskind from Australia is actually the lead author. What about clozapine during a pandemic? Because the issue is, the FDA mandates, once you're stable a year on clozapine, monthly blood work. To check for ANC, and different countries have different protocols, but it became clear this may be a problem. All right, we're trying to limit in-person contact, and blood draw is an in-person contact. Is the way around this now? Thankfully, through some lobbying efforts, and many of us collectively, the FDA issued a ruling that basically, in complicated language, says you have flexibility to not necessarily have to do the blood work every month. They're not going into great detail. So this is where this consensus document comes in. We try to specify criteria, for example, giving people a 90-day supply. Okay. So that they really only need to be seen for blood work every 3 months. Now, this requires, of course, you talk with the patients, their families, they need to be buy-in, acknowledging the risks. You need to have a pharmacist who understands the rationale for this and agrees with it. So this then, on the other hand, allowed us to free us, if you will, our resources, fewer people in clinic, but we are still working to then, again, this is a very important point, not to see people every 3 months, we still see monthly, but the other months, we see him with a phone call, for example. So we have basically, the pandemic forced us to create a much more flexible and I think patient-centered model.
Okay. All right. Let's go along with that theme. I mean, I'm glad you talked with us about that, how we can work with how your clinic works with clozapine, all right, in the midst of this pandemic. I wanted to go to long-acting injectables because I'm curious in regards to the long-acting injectables. For instance, do you also use the same ratio of long-acting injectables, or have you switched to those with, if you will, longer durations of action, such as either 4 or 12 weeks, such as like a paliperidone? Are you all using the olanzapine long-acting injectable, and if so, the 2 or the 4 week one? I'm just curious if you have gone to LAIs with longer durations of action during the pandemic, or if you've kept it the same.
Yeah, great question. And we created, the 2 nurses and myself, if you will, in our clinic, in our injection clinic, a little workforce to think about exactly this issue. Again, the guiding principle here during a pandemic is limit foot traffic, limit in-person contact while maintaining psychiatric stability. So, and I was shout out, if you don't mind, to a APA initiative, the SMI advisors. I'm part of this group. You may be familiar with it. They actually focus, among other things, on clozapine and long-acting injectables. And there is some material that we together created that addresses your questions a little bit. Without going too much into specifics, we really looked at all our patients in the clinic. So you have to do population-based management. You look at step back, look at all the people, see what they're on, and then for each patient you got to make a decision. And the decision is, assuming you think you can do it safely, is there a way to move to a longer acting long-acting injectable? And again, just like clozapine, doesn't mean that you see people less frequently. You would just see them less frequently in person. You still augment, your frequency of visits, with telehealth.
Okay.
There are some situations in group homes, people end up on long actings. It seems easier. Maybe there is actually a time where, if there's supervision, to temporarily during the pandemic switch them back to oral pills to avoid the injection. We actually have a paper under consideration right now in Journal of Clinical Psychiatry that looks actually documents that we successfully managed to reduce basically the number of in-person visits or encounters by looking at the population level at our patients, and we really didn't see. Now, of course, we made clinical judgments, who not to change, but we really didn't see any decompensations from our changes that we made.
All right. Well, thanks for sharing that with us. I mean, hopefully in the show notes, we need to include that link to the APA's SIMS serious mental illness work, and shout out to them. And also Dr. Freudenreich was giving shout outs to folks. I want to just shout out everybody in community-based clinics across the country that are doing this work. I got I swear by my training at the Bronx VA, but I'm blanking on the community clinic, which was a homeless shelter that I trained in. It was a part of Mount Sinai where I got the best training of my life. The clinician told me every day she battles despair, and I've always kept that in my mind. Now, with that being said, let's go back to Clozaril and long-acting injectables. What happens, have you had the experience of one of your patients in a community clinic, all right, or your schizophrenia program actually contracting COVID-19?
Very interesting, because at the beginning, we were extremely worried.
Yes.
I in Boston, you may have heard this because it got a lot of publicity, and we do have a homeless shelter in our building. And the homeless population, for example, it turned out that the rate of infections was significant. And the most disturbing thing, that's why I think we were worried very early. Most people didn't have symptoms. So when you see it's called pandemic theater or safety theater, when you see people, with their devices to measure the temperature, I'm just laughing. I mean, I'm not, I shouldn't say this here, but you know what I mean. We are going to miss the vast majority of patients. If you're that sick that you have a fever, well, it's going to be rather obvious. I don't need anyone, with a device checking temperatures. And in this cohort study that Dr. Baggett, spearheaded in Boston, they really found that they have to do some sort of surveillance testing. And so very clearly it became clear to us, just relying on clinical markers is not going to work. That was one of the reasons we very early implemented in and out, because we realized, other than testing, which we did not have access to at the beginning, easy testing, routine testing, we would not know, that we would be exposing ourselves for prolonged periods of time to somebody with disease, COVID disease in the clinic.
With all the work that you all are doing, have you had one of your patients in either one of your settings actually test positive for COVID-19? And did you have to make changes in your management?
Yeah. So give a lot of credit here to Magnola, the chief medical officer of North Suffolk, North Suffolk Mental Health Association, who very early decided that it would really be a priority for them to avoid, we manage a lot of group homes, to avoid infections in group homes. And they paid a lot of money, truthfully, to have staff members stay with patients during this initial surge, not go in and out. They lived with patients in group homes. And as a result, we had very, very few cases of COVID. Something, we'll have to see during this ongoing, not really a second wave, right? In the US, we kind of had a wave that never really abated.
That's
But so we'll have to see. I think we have to remain humble, Lorenzo. We have to remain humble. There is an element of luck in a pandemic. I think in some way we lucked out at the beginning that we actually did not have somebody who infected a whole lot of people without us realizing it. Now I think the element of luck is constrained a little bit by I think we are doing a reasonably good job with infection control, but we still could get unlucky.
We still could. No, we absolutely could. And I think, again, we think about in terms of those principles in patients with serious mental illness. And actually, I'm going to start with what you said earlier. I think the first principle is don't underestimate their level of resilience, because do not underestimate the level of resilience. But then we talked about, again, what are you actually doing in your own environment to keep your staff and your folks safe? We're going to go back to what you said again in terms of the audience listening, in and out. in and out, but that does not mean that you reduce the level of contact. That just means you change the ratio. All right. So we go tele, but again, in terms of what, ask yourself this question, as Dr. Freudenreich just illustrated with us, what is absolutely essential and important? And then after that, you can start to look at what modifications that you need to make in regards to Clozaril, long-acting injectables. We could also say the same thing in regards to other medications, but we're going to focus on those.
Correct, yeah.
For right now, because I think that those are definitely very relevant. And then you start to think about, and this is where I completely agree with you, I think everyone has to start to think about what is their plan if one of their patients becomes COVID-19 positive. And by that, I mean, like, how do you continue to work with that patient? Do you have a referral mechanism? Are they, depending on where they're at, are they going to go to a COVID hotel? Clearly, if they were symptomatic, having difficulty breathing, dropping O2 sets, you'd just be sending them to the hospital. But all of these things, and you need to really think about them in a systematic fashion. And now I'm piggybacking a bit off of what Dr. Freudenreich said in terms of getting he said, I would agree, getting a bit lucky, but what I equate that with is that it's different in different parts of the country, as well as based off of your resource. So even though Dr. Freudenreich is talking to you about these principles, you're going to have to it's really our principles that you're going to have to adapt to your own location in your own environment, because this is, with the pandemic, change is the rule. Change is the rule.
Incredibly important what you just said. Yes, we can delineate some general principles. All solutions are local.
Yeah.
All solutions are local. All politics is local. A famous Massachusetts politician once said. And I think this is really something that people need to fully understand. We are just used, I think, clozapine and long-acting injectables as a paradigm.
Yes.
Depending, if you do opiate management, totally different issues,
Totally different.
but same general principles that you need to think about. How to get your patients through this pandemic.
Absolutely.
I loved how you put it, by the way, that the ratio of in-person and other ways of engaging patients is the key. The amount of visits actually remains stable. That's a good way of looking at it. Can I come back to something that you said? You mentioned resilience, because there is something I think that people need to understand now, and that worries me to some extent. Yes, I think people have surprised us and been more resilient than many of us suspected our patients to be. But the pandemic has been going on for a long, long time now. In pandemic management, there's a graph, and one of the phases before the recovery is called disillusionment. And I'm worried that there's an element of this. I'm almost more worried though, and if you allow me to use an image here as a European, as a German, World War II ended for Germany on May 8, 1945. You don't want to be killed on May 7. I really urge everybody, staff and patients, whoever is listening to this, to recognize we are so close to getting vaccinated and being protected from this virus. Every clinic needs to understand that what they do now, every infection that they prevent is going to be a death prevented, potentially. Because the vaccine, I look at 2021 as a year of digging out. Depending where you're in the country and what role you play, you're very close to getting vaccinated and protected. So let's just acknowledging that it has been hard and the winter is going to be hard. Let's appreciate the seriousness of the ongoing pandemic. Make it through until we're all vaccinated.
All right, Dr. Freudenreich. In regards to what we're talking about, again, you've given us, many principles, if you will, of pandemic management. You mentioned something that was very important. You mentioned in regards to that disillusionment phase. All right. And again, for those of you listening in the audience, we're thinking about the emotional phases of disaster, the collective reactions. Zunin and Myers came up with, as well as DeWolf. You can actually, there's copies of this. All you have to do is Google it, but you can also go to the SAMHSA website amongst many other places. So we're out of pre-disaster, we're out of impact and heroic. I remember what that was like. Honeymoon, we're definitively in disillusionment. All right. what you mentioned before, what was one of your biggest concerns in regards to disillusionment? Is there anything that, in terms of education or things that you do for your patients as well as your staff, that you recommend in terms of that principle of pandemic management to help people navigate that disillusionment phase?
Yeah, I do concretely. I actually show people this graph,
Okay.
and I give them a term for this. Disillusionment. Sometimes I might use something like demoralization, particularly, if people, had deaths in the family or been affected in other ways. But I also use this graph to give them hope.
Yeah.
Okay. And I think, you have to realize that the scientific progress has been astounding. We can give people real hope now, I believe, with several vaccines coming aboard. And so I think just pointing out to people, there's light at the end of the tunnel, and it may be more than just New Jersey. Sorry to all the people from New York and New Jersey, that there is actual light at the end of the tunnel, but not to become reckless now. Right. I think this is at this point in time, this is actually the key message. I would not have been able to give people this message really a month ago. So I think it's an example how rapidly things really shift. I want to point out, though, that people, when they look at this graph, have to realize this graph is really a scheme for a one-time impact.
Exactly.
One-time impact. So it may apply and it may not apply, and I think it's a little bit more complicated. The other phase that I want to just briefly talk about is this idea of reconstruction, because that worries me. And you may ask what worries me about it. Well, I already praised a little bit our governor here in Massachusetts for making some very clear decisions, executive decisions, for example, that the Mass Health insurance in Massachusetts is going to pay for telephone services, no questions asked. It's going to be part of standard of care during the pandemic. I am very worried that, as opposed to building back better, which is really the hope, that we're just going to go back to the dysfunctional ways that we had before. I think the pandemic has leashed some innovative stuff that we were forced to do. Like you nicely mentioned, this ratio between inpatient, other types of visits, right? I think this is innovative. Maybe not rocket science, but innovative for our field. And it would be a shame, wouldn't it, if we lost some of this?
It would be a tremendous shame, particularly as we work our way through these phases of the pandemic. And I think about in society, take your pick, where simple interventions can make huge, just practical common sense things. Buckle your seatbelt, stop smoking. It just makes sense that we literally, and I mean everybody listening to this, everybody in this country, we transitioned to telehealth in 3 to 4 weeks because we had to. It would be, I agree with you, it would be tragic to not keep many of these innovative approaches that are really helping us reach patients more in terms of, if you will, at least access. It helps solve one issue with mental health care, which is access. It's not going to actually really get into like volume or the numbers that we need. But you mentioned something else that I thought was
one follow-up, though, really important. I already mentioned the term digital divide earlier.
Yeah.
Let's also appreciate the fact that not everybody is bright-eyed and bushy-tailed about telepsychiatry.
Yeah.
There is a group of patients who love to come into clinic. There's a group of patients who are just having a cell phone is not enough. What if you don't have access to stable internet? It simply doesn't work. And, we have seen problems there. So I do think we need to be careful and not leave those people in the dust who, for whatever reasons, are not willing to jump on the technological, bandwagon.
I agree with you completely, Dr. Freudenreich, in that the way I think about it, it's in your clinic, I thought illustrated it wonderfully. It's not either or, it's and what ratio you add it. And how can we better add more tools to better serve our patients? So we don't want to take away tools that we know that we've been working on because I spoke with Dr. Yellowlease in a separate site cast. We don't want to take away, in terms of telehealth, we don't want to take away tools that people have been working on for decades. We want to add tools and then let patients and clinicians choose. But I want to go back to what you said in regards to that last phase. This is my biggest concern. You talked about it, because you could argue that the first wave, depending on where you're at, and I kind of was making this argument to folks, in certain ways, I never thought the first wave really stopped. I just thought there might have been a first wave that kind of plateaued a little bit, but it never really stopped. And we knew from H1N1, we knew that a second wave was coming. Everyone kept on saying it, but similar to our patients, that's going back to what you said, we're all in the same boat, aren't we? Even as a clinician, even though I knew the second wave was coming, even though I was giving lectures on it, I still was hoping like, okay, well, maybe it won't be as bad, or maybe, no, we knew it was going to be as bad. And one of the things when I think about that emotional phases of response to a disaster is when they normally graph this over a year. And that's when you maybe like right around, you would hope to start the reconstruction. For me, the biggest issue right now is that when people are right in the disillusionment, they get hit again by a second wave that's even stronger. And I think that we have to really, and we illustrated a bit of this right now, I believe that we have to emphasize psychological flexibility in terms of how, and that actually is a term for folks out there, in ways in which we choose our coping, because let us not forget, and I'm going to turn this back over to Dr. Freudenreich, because it absolutely is relevant for our patients with serious mental illness. Suicide rates in this country have been rising since 1999. All right. We have had, before there was a coronavirus pandemic, there was a suicide epidemic. There was an opiate epidemic. There was a, take your pick. So we in this country, in terms of mental health, we were already in a very, very, very challenging situation, but particularly our patients with serious mental illness. So I just think it becomes so vitally important that we realize that even with that resilience for us and our patients, we're taking another double hit. So Dr. Freudenreich, I turn it back over to you, sir.
Incredibly important point. And that is, it's anecdotal. So, as an academic clinician, careful with anecdotes. Yeah. But very clearly, as much as I praised our patients for being resilient, they are getting hit and hit again. And it is something to really appreciate. I am worried that the next 3 months, all the good coping that people have is gonna get more brittle, and we will have people, where suicide becomes an issue, where drug overdoses become an issue. So I am worried about this. You mentioned resilience, and a slightly different term that I want your audience to think about is the idea of deliberate resilience building. Because, and it's just unfortunate, because I think often we don't focus on people with serious mental illness. Mm-hmm. There's a lot of, building up resilience in high school students, for example. Mm-hmm. Mm-hmm. The same principles apply to people with serious mental illness. There is a way to deliberately build your resilience. And this is important because some people assume, resilience is just something that's inherited that you have or you don't. Mm. Completely wrong. And I encourage people to look up, this technical term, deliberate resilience building, and they'll find ways, what is self-care? What are aspects of self-care? Would be one aspect of this. Maybe some people are more philosophically inclined. The Stoic philosophy has come to the foreground a little bit. It's actually the living in the moment idea, focusing on things that are going well. So there are some even philosophical approaches that have had a renaissance during the pandemic, because people realize, well, maybe there might be some value in these third wave psychotherapies, or positive psychiatry is actually a term now that focuses on resilience building as opposed to just psychopathology. And I think the pandemic may be a way for us to think about step back, also building back better, creating a healthcare system for people with serious mental illness that emphasizing their ability, take their strengths that they have, but make them even stronger, and not just see them as victims of something.
Okay. All right. Dr. Freudenreich, I think you said it best. You've given us so much information here to think about in terms of principles of pandemic management, starting with one, how we always continuously think about logistical and procedural things such as our PPE, as well as how we think about our actual environment and how we're going to manage our patients, and in collaboration with them, I must add, in regards to the ratio of in versus out. We also have to take into account that while our patients are affected by the pandemic and they show resilience as well as we do, but everybody's affected to it. You took us through, again, thinking about it, again, more principles in regards to medication management, particularly focusing on clozapine and long-acting injectables, and the need to develop, if you will, based off of where you're at, things that make sense for you. And there's literature out there, and your group has talked about this. And then the final thing is we go through the emotional phases of a disaster response. Take that chart, take it with your patients. Because I think I might actually start doing it now. I'll give you credit for it. Take that chart and do it with your patients, and trust that they're going to understand it. And what that can be educational, but that can also generate hope. And I'm going to leave it with the last thing that Dr. Freudenreich said: deliberate resilience. Deliberate resilience. Maybe out of the end of all of this, we'll start to have a healthcare system that's more focused on growth paradigms than strictly disease paradigms. Dr. Freudenreich, sir, I want to thank you. I give a big shout out to all the folks up in your clinic, up in Boston and Massachusetts doing their thing. To everybody out there right now, keep your wind up. I know folks are tired, but you got to just keep up doing what you got to, and do what you have to do to make it through this. And there is light at the end of the tunnel. Dr. Freudenreich, thank you very much.
Lorenzo, I appreciate the time that you gave me to talk a little bit about our experience, and I wish everybody stay strong here for the next few months, and then we'll see the light. Thank you so much for having me.
And that's it for episode 152 of the Psychcast. The Psychcast is produced by MDedge editors Gina Henderson and Jeff Bauer. All of our podcasts are produced by Kathy Scarbeck. You're listening to the Psychcast by MDedge.